Dr. Mark Abramson. Also, Courtney Snow is on the line as my partner in webinars. Dr. Abramson was probably one of the first dental radiologists in the world. And I met Mark Abramson way back when he was treating TMD. And since then, he's been doing a lot of sleep apnea appliances. In fact, Dr. Abramson teaches sleep apnea appliance therapy and meditation therapy at Stanford as well. Dr. Abramson is very accomplished. He's invented his own appliance called the OSA. So welcome, Mark.
Hi, how you doing, Rose? I haven't seen you in a long time.
Yeah, we just actually last weekend.
We should still be in Minnesota.
I know. It's hard to read us, but thank you so much for joining us, and we're so looking forward.
I understand there's over 100,000 doctors out there listening to this.
This is correct.
Okay, good.
So, we're really excited about your webinar tonight. Thank you for joining us.
Well, it's my pleasure. So, should I begin?
Absolutely.
Okay. So what I want to start with is that basically we have, there's the main reason that we have this field of sleep apnea is because of human advancement to speak. So we've opened our throat up and created the oral pharynx, which is not present in any other mammals. If those of you who are kind of following the Triple Crown, the horse racing, and the controversy about whether California Crump was going to be able to wear his nasal dilators, I was talking to John Remmers in Minnesota, and the reason for that is horses and all other mammals are obligatory nasal breathers, and it's only humans that actually have the capacity to breathe through their mouth. Dogs can pant, but really the breathing is through the nose. And when horses race hard, they basically are working themselves so hard that they can get congestive heart failure, and they didn't want to risk the horse without the nasal dilators. And I thought that was very interesting because a lot of my focus initially was been on the fact that we need to address nasal resistance. And John Remmers, who Rose and John and I talked together for a number of years, he's very focused on treating the nasal resistance and saying that that we can't ignore that any longer. That a quote from him is that 30% of the patients absolutely require treatment of their nasal passage. 80% will benefit, and 20% it doesn't really need it. So all appliances have one thing in common: they're moving the jaw bone forward. And the picture that you have on the computer right now is a research article called The Passive Pharynx. And what this is on the top row are, this is a patient under anesthesia, and they have CPAP pressure, and the one is with just the mandible in its rest position, the other is mandible in protrusion. And as you go and they lower the CPAP pressure, it starts at 20, and then you can see the numbers as it goes down to about 6 or 8, you start to see that the mandible that's not protruded, that the the pharynx is closing, and by 2 to 4, what is that centimeters of water, then the pharynx is closed off. So what we're hoping that we can do with oral appliances open the pharynx by repositioning the jaw. And what we want to look at, so this is airflow, and you can see in this, the top, I don't know how familiar you are with looking at the airflow measurements, but this is a resistive airflow because the flattening of the top of the curve on the airflow, and you can see the PSG stands for pressure, esophageal pressure, and you can see, you're going to compare this to the next slide. You can see that the esophageal pressure is pretty high, and also the EMG is high on this. as compared to with mandibular protrusion, you see a nice airflow, you see actually lower negative pressure and quiet muscles. So the concept that it's activation of the genioglossus muscle that keeps things open is not actually accurate. It's does the repositioning open the back of the throat, and the genioglossus actually is more relaxed in the open airway. So if we look at all the appliances that we have on the market, that they're all doing this one thing, and they do it very well. They reposition the jawbone. And the real hope is that we can get the airway to open with that. And we're going to look at some of the things that we need to address. So what I focused on, and I had this problem, so I was one of the 30% that if you just brought my jawbone forward, you would not address my airway problem because I have significant nasal resistance. And because of that, that's where I saw how important it was for myself. And then, so I wanted to, so let's look at nasal influence on healthy respiration. And the first thing that the easiest way to assess this is simply as you're seeing your patient come in, you want to do a Cottle maneuver. A Cottle maneuver is an ENT test where you basically just pull the sides of the nose apart, pull the skin, and it pulls on the nasal valve area. The nasal valve is where 90% of the resistance in the whole respiratory tree is, so it's the startling resistor that will determine the resistance to breathing in throughout the airway unless it's blocked in the throat. So in a normal functioning airway, that's where you're going to have that startling resistor. So this determines if the nasal valve is the significant area of obstruction. It's very easy to do. You just stretch the skin apart like this, and you start off without the stretch, and you ask the patient to feel the resistance of the breathing, and then you stretch and ask them to breathe again. And very often you get this kind of wow factor. Oh my God, I can't believe I can breathe so much easier. And it's quite demonstrative for the patient, and it shows you that you can affect the nasal airway with proper care without surgery. So let's look at some of the research on the nose. So if we look at what's significant in the research as far as the problems in the nose that are going to reflect on the actual AHI here is unilateral restriction is actually worse than general restriction, and that's predictive of a high respiratory disturbance index, or you could say AHI is the same thing. And part of the reason for this is that they have a nasal cycle. So what happens is that the turbinates, particularly the inferior turbinate, is very high vascular tissue. It's sinusoidal tissue, exactly similar to penile erectile tissue. And so what happens is that usually you're supposed to breathe through just one nostril at a time. And so one side of the nose will swell up and engorge and block off that side, and the other side will shrink up. And so if the left side is engorged, the right side will shrink, and you're breathing through the right side. And it's a 2 to 4 cycle where you go, and then the other side will swell, and you'll switch to breathing through your left side. So you can see that if you have a very significant unilateral blockage, when you're supposed to be breathing out of that side, you're going to have a blockage. So this is, it also corresponds with something called an ultradidian cycle. They think of the hemisphere. Your brain actually has more activity on one side than the other, which corresponds to this. But we don't have to worry about that. We just need to focus on the fact that one side of your nose is going to be more open than the other side, and if you have a unilateral blockage, it's going to impact AHI. So we want to take care of that. So then we have REM, and you know that in the REM cycle, the AHI is going to be much more significant, and what everybody has given as the reason for that, which is surely significant and true, is the fact that in REM all the muscles paralyzed. So any of the muscles that you're using to maintain your airway are not going to be functioning during REM. But what also happens during REM is we get erections. And not only is that happening in the penis, but it's happening in the nose. So even if you have a patient that's relatively normal in the wake state, when they lay down, and particularly when they go into REM, that their nasal airway is going to be much more congested, and therefore it's actually been postulated that one of the reasons for the increase in AHI during REM is also the nasal congestion. So we want to recognize that there's particular physiology of sleep, we're going to have much more problems with nasal airflow. Then the thing that, if you have a mouth breather, that the AHI is significantly higher. And the real significant thing of this research article with McLean et al. Is that if you open the nose, patients will breathe through it. So if you give them the opportunity to breathe through their nose, they will prefer to breathe through their nose. And I don't know if any of you, if I have a cold or flu and I have to breathe through my nose at night, I will, it's a very unpleasant thing, and I actually put my device in and my nose will open up in the times that that's happened. So if we know there's plenty of research showing that mouth breathing is much more significantly higher AHI, and I'll just kind of go through these relatively quickly. So you want to breathe through your nose when you're sleeping, and particularly in the supine stage 2, there's more upper airway resistance, and then obstructive apneas and hypotony are fairly more frequent when breathing orally. So we know that, and that excuse me so we can go through that. So and the nose and OSA, so variable nasal obstruction. I'm going to go through some of these pretty quickly, but some of the important things to recognize in the benefit of breathing through the nose is there's actually a reflex that stimulates respiration that is stimulated through nasal breathing that is not present in oral breathing. So there's upper airway dilating. So the nasal breathing has a stimulant effect on breathing, and there's upper airway dilating muscle activity that is activated through the nasal breathing. And when you, the reason you know that this is a reflex, if you spray local anesthetic into the nose, you actually shut off this reflex activity from nasal breathing. And then when I developed the OASIS, we did research, and here's 187 adults, 98 males, 89 females, and we did rhinometry with and without the nasal dilation, and we found out that in the nasal valve area, which is the significant area, the most restricted area, that the area was 14% wider, and in the more distal regions, it was actually even open more. But if you have Peshet's law, that you have this 14% represents 50% more air flowing through the nose and significant reduction in resistance in breathing, which you can feel yourself by doing a Cottle maneuver. So we documented that and published that. And I'm going to go through this again quick. And so, and actually I'm going to go out of here, and we're going to go through this a little bit more quickly. So if we look at, coming down here, if we look at the two areas that we really should be addressing here, we have the nose, which creates resistance. If it's completely blocked, you can always transfer to breathing through your mouth. And then you have the back of the throat, which is where you get the blockage. So we should treat both of these areas if we can and have the effect. And we know growth and development, how important this is. This is a great swimmer, but he is not a great nose breather. And actually, it's a benefit for swimmers to breathe through their mouth because they're less sensitive to CO2 and they can hold their breath longer. So this great body has to hold his mouth together by using his mentalis muscle. So I developed the OASIS, and these dilators at the top there. That's what they do. They basically do a paddle maneuver all night long. So the other goal was to look at tongue space. And this is why actually when I did the OASIS that we made the shield in the front, because I wanted to have maximum tongue space. And so we're really, the whole reason for bringing the jaw forward is to bring the tongue with it. And so we want to look at how we might impact that, because what I'm finding is that a lot of times we bring the jawbone forward because of poor function of the tongue, the jawbone isn't coming forward with it. So in the upper piece that we use, we have just a cushion in the top, and we've actually recently even cut off the lingual of the upper anteriors, because we want the natural feel of the tongue it's much more comfortable for the tongue to feel its natural tooth surface than to even a thin layer of acrylic. So we want to basically give all the good reasons for the tongue to want to come forward with the jawbone that we're bringing forward. So as we look at how can we address tongue function in our patient, and so we know from the research that if we do oral exercises, that we see a reduction in the AHI. So this is a study that was done in Sao Paulo Medical School, and the outcome of this was teaching 3 months of intensive speech therapy, and they got improvement in the AHI. So this study points to the fact that if we can use the muscles of the tongue and the throat better and make the muscles that we need to protect the airway stronger, that we can get improved function and lower the sleep apnea. So what I started to do was to look at tongues, because I realized that I needed to know a lot more, and I wasn't really looking well enough. And what I noticed is that as I had patients open their mouths, we could see that a lot of the patients, their tongue was actually rolled up in the back of their throat, and the tip of the tongue was at the second molars. And so bringing the jawbone forward in these cases isn't going to bring the tongue or the soft tissue. So really, the whole reason for bringing the bone forward is what we're going to do to help the soft tissue come forward. And then this is looking at tongues that would come forward with repositioning, better, more healthy tongues. So characteristics of a proper tongue function is lips closed with nasal breathing all day and night. The resting tongue posture is in the roof of the mouth with no tooth pressures. Swallowing pattern is palatal and posterior. So as you swallow, you're pushing your tongue up against the palate and rolling it back, and the peristaltic movement going posterior. Lips are strong and well toned, and oral facial muscles function in balance to support the dental arch, bite, and jaw joint apparatus in speech. So we want to have good tongue function. So even in this picture here, where we have the nasal pharynx, the oral pharynx, and the laryngeal pharynx, you can see that space as they're drawing of the tongue being low in the closed mouth position. And what the tongue, I'm going to go back one, sorry about that. Let's see, I'm not going to be able to go back. Let me go this way one more time. And we'll move back here. Okay. So what the tongue should function as is the tongue should function as a spine that holds the jaw in space. I feel like for the first time in my life, I understand the term freeway space and what freeway space is. And freeway space is, I'm going to use one example of proprioception that is not stable. And so you go to a restaurant and you have a table that tips a little bit, and it drives you batty. You tell the waiter, either put something on a coaster under the table to balance it out, or move me to a new table so I can relax. And what that is that the brain wants to have stable reference points. And you have a patient who's bruxer or clencher, and you say, relax your jaw. and you have a jaw that opens up in space, but that jaw is not stable. It's kind of hanging in space. And what we're supposed to have in good function is the tongue up against the palate. One of the doctors at the meeting we just had called it the kickstand. We want the kickstand set. And then you can have the jaw being stable in space. And then you'll have a stable freeway space. So we need the tongue up against the roof of the mouth, being a central pillar or spine to support the jaw in space. And if we don't have that, the only stable position is teeth together and jaw clenched. So that's where you're going to have clenching and bruxism without the jaw stabilizing the jointed space. And as Rose mentioned, I head the Stanford Mindfulness-Based Stress Reduction Clinic. I've done this for 18 years here, and it's become a very big program. But teaching stress reduction, I would wonder why I'd wake up with sore muscles in the morning. Am I a total hypocrite? And I realized I had very poor swallowing and tongue function myself. And when I figured out a way to correct this, now finally my muscles are relaxed and functioning the way they're supposed to be. So without proper tongue function, we can't have the proper balance of muscles in the craniofacial region. So we've got to get that right. So I started looking again at tongues. It's just a palm being CT with the jaw closed, and you can see that tongue in the back of the throat. And this is an awake patient with very poor function and a very compromised airway. You can imagine what's happening to that patient in sleep. And if you just bring that jawbone forward, you're not going to have success with this case. So we needed to address the tongue function. So once we have the tongue locked up to the palate, then you can bring the bone forward and you're going to really open the airway. But you have to have that tongue engaged to the palate where it's supposed to be. And unfortunately, very few people have good tongue function. So we have a problem here. So here's a patient you can see in the closed cone beam, the space between the tongue and the palate. And you can see with an oral appliance, what happens to this tongue, it basically rolls up. It's not going to be stable. It's going to be prone to fall back. And this is a case that oral appliance therapy is probably not going to be successful for. And now we know why. So you're not going to get the opening that you want to get in the airway here. And we've all worked with patients with tongue thrust, and we know how hard it is to get the tongue to change its pattern. So we're basically telling a patient what to do and to do the correct thing is going to be very hard to translate if the patient actually doing this. So what I started to do was look at a way to help the tongue to go forward and go in the right position. And you can see here again, one of the definitions of the tongue should be no pressure against the teeth. And we all know that scalloped tongue is one of the correlations of having a sleep apnea problem. If you see a patient with scalloped tongue, that means that the patient has a good chance of also having airway problems. So the various functions. So the first thing I did was I tried to put a ledge in the front of the tongue to lift the tip of the tongue. And what I found was that was actually a bad thing to do in a lot of patients, because what happened is the tongue would end up slipping back behind that shelf. The same thing that happens in the mandibular tori. So if you see patients with large mandibular tori, you want to see what the tongue's doing, and very often the tongue will be going behind the tori and therefore back into the throat. And if it went over the tori and the tori helped it stay up against the palate, that would actually be a good thing. But very often that's not what happens. So I realized that I had to target a different area. And what the idea I had was that let's target the root of the tongue, the base of the tongue. And so I started to make extensions similar to what I did with the nasal dilators, and put them under the tongue to basically address the base of the tongue and push the tongue up into the palate. And I was the first patient to try this on, and I had been trying to change my tongue swallowing, studying with oral biologists for literally 30 years, and was not successful in changing my own throat pattern. And about it and talk about it all the time, and I'm more motivated to do it than the average patient would be who gets busy in their life. So within 2 weeks, my tongue is locked up against my palate, and I can tell you it's an unbelievable difference. I used to have problems swallowing vitamins. The joke in my family is Daddy's going to die taking vitamins. I couldn't sing, not that I'm a great singer now, but my whole voice has changed, my throat function has changed, and I can tell you it's delightful to have the comfort of having the tongue functioning correctly, as well as what it has the airway. So in patients like this is the target area that we want to address to get the tongue up and to get the tongue function. And what this also does is it helps patients, they can't be lazy with their swallow. They have to use all their muscles. And I tell patients, as you do this, it's going to also help your lymphatics, because the lymphatic system moves by the proper muscle function, and you're going to be using your throat and facial muscles better, and it's going to help you both in your wake and your sleep. So this is what we did. We targeted to get the tongue up. And once we get the tongue engaged where it's supposed to be, then we can move the jawbone forward, and we're going to get the airway opening up. So this is where we develop these nasal dilators along with we call them tongue activators. And we're also, one of the very exciting things that we're doing, and let me see if I can, if I have a video about it here, but we're also using this for kids. And I actually hope to develop a whole new field called dental speech therapy. And Rose, let me know, make sure that they can hear this when the S's.
Sure. So the S's are, it's a lot easier to make the S sounds. It used to be really difficult. I had to do it slowly, and now it's coming more fluidly. Our practice is almost.
Can you show us?
Not generalized, so when she's trying to get her point across and not thinking about the sound, but still there's a lot of tongue thrust. But before, she couldn't even make the sound, even when she was thinking about it.
Right.
So now when we go for exercises, the S's are consistently very good.
Great. All right. Thank you.
Yes, Mark, we couldn't do that perfectly.
That Alexa is enunciating her words well, and her pronunciation has improved. And also the teacher Pat, who Alexa goes to for speech help, has now recommended that we switch to variability every other day. And we noticed that Alexa came a lot of the sounds with the X's, and what are the other special ones? Letters like the R's, that's right. And all those, and now she's even teaching me how to pronounce them, and she's teaching Grandma how to do their pronunciation. Is that right? Yeah. Okay, do you want to tell us the numbers you want to count? 61? Or will you?
61, 62, 63, 64, 65, 66, 67, 68, 59, 70, 71, 72, 73, 74, 75, 77, 78, 79, 80.
Yeah, much better.
Good job.
So what we do here in the initial group is
Stick your tongue out.
little science.
Okay. There you go.
It has vacation and all things?
I had a fun time on vacation.
What'd you do?
I went to New York.
Uh-huh.
And I went to Legoland.
Uh-huh.
And we went to Legoland for a week, right? Fun.
You happy?
Yeah.
Good. Good.
Trevor's speech is dramatically improved. He's doing great. He was wearing that device religiously, and over the past few weeks, he has been wearing it. Speech just continues to be improved. His S's are clear, and he has no problem pronouncing them, and does it without effort now. When he used to really have to be conscious of it and focus to pronounce his S's clearly. So he's doing great.
So what we're doing is we're showing that with this particular appliance, and this is what it looks like, that the kids just wear it at night in their sleep. And we're changing the way that they swallow and the way that they use their throat. And so we're catalyzing these changes that are so important in so many ways. So that's what I hope to see in the future is that as dentists that we're working with speech pathologists so we can get these kids working in the right direction and improving their. Rose, were you saying something to me? Or?
I was just saying we could hear that video perfectly.
Oh,
That's
okay.
amazing.
Yeah, isn't that wonderful?
No,
And the
thank you
kids,
for sharing.
the kids just light up because they know that they're having a problem. They feel self-conscious about it, and it's hard to get them to talk initially, and then when they start to speak better, you can't get them to shut up. So
That was awesome.
all right. So next I want to show you what we need to do for titration. So each appliance has advantages and disadvantages, and the ease of titration. The tap was originally probably the easiest because of the piece that stuck out the mouth, and you could just twist it and bring the jaw further forward in a sleep study, sometimes not even needing to wake the patient up. But what we're finding, John Bixby, who just, I'll show you his thing of 170 patients that he's cataloged, continual patients, and that he works in a sleep lab that has fantastic follow-up. So basically, every patient has a PSG pre and a PSG follow-up, which is a titration study, rather than thinking that you have the appliance in the right place, unless and you're taking a snapshot of that, and it worked great or it didn't work. That we should be having titration just like CPAP does, where you turn up the CPAP pressure until you get the effect that you want. So what we developed for the Oasis is a simpler way to do it, where these are dental X-ray badges, just bite wing tabs, and we use half of it, and it's 1 millimeter thick. And so you do have to wake the patient up. You start the patient off for the first 90 minutes, and the technicians are told to, if they're still having events, to wake the patient up. They put one strip in, and they do another 90 minutes of study. And then if that doesn't work, then you can put a second one on this, and usually 2 is as much as you need. And John has been doing a great job in looking at his results. And this right here is the sheet of all his results that he has, and he's categorized them as like, here's a severe, very severe would be over 50. So here's like a severe that was AHI of 64, low oxygen of 87, and it went down to 1.2 with a low oxygen 92. And I just think this went out random, by the way. And so he looked at the responders and the non-responders. So here's a very severe that went down to moderate. So it started off almost 80, oxygen low around 80, and it only went down to 27. Oxygen went up to 87. So here's a patient that responded. We would call that a responder, but these patients, and then what he did on some of the patients that didn't completely respond is he did co-therapy to have them on airways. So if you look at all his results here, and we look at all the patients in this list, that if we use the acceptance criteria of success as getting them 5 or below, 70% of those patients were able to get down to 5 or below. If we look at the getting down to 10 or below, which is very much one of the accepted standards, 85% of the patients were able to achieve that. And starting with mild patients, 96% went down to none. So if we look at that, you can calculate it a different way. If we look at the severe patients, severe to none, almost half of them he was able to get severe to none. If you were at the meeting this week and looked at the average statistics, this is incredible. This is a very, very excellent response because of good titration and hopefully good appliance. Very severe, over 50 to none, 43%. So that's very severe to mild was 64%. So moderate to none, 63%, and mild to none, 96%. So this is very well documented, and what it is using good titration, and he's in a wonderful model for us where he can do titration. Now, he took, these are patients that he had that failed CPAP. So these patients started out as CPAP failures. Then he tried oral appliance, and these were not complete responders. So he did combination therapy on this, and the original CPAP level was here on this first patient was 12, went down to 9, a 25% reduction. The original baseline AHI was 21.3, and with the CPAP went down to 4.1. So here's again 12, went down to 9, a 25% reduction, started at 55, went down to 5. And 10, 7, so 30% reduction. So on average, he reduced the CPAP pressure by 36.06 and reduced the average AHI. Let's see, I don't know if I have the average here, but you can see every one of these patients was successfully treated. And these were previous CPAP failures that were able to tolerate with the oral appliance. And what we used for that was a combination of using a CPAP Pro with the Oasis. So this was appliance without the headgear. Keith Thornton has a very nice mask that he uses that can be used on we're going to be also using that on our appliance. It's a very well designed nasal pillow system that attaches to oral appliances, and this doesn't look very comfortable, but patients find it that because of the lack of strapping and headgear and the reduction in the pressure that they use, that they can do it now tolerate and be successfully treated. So let's see, any other things that we want to cover here? I guess we'll open it up for questions now. Rose?
Okay, great. Now, if for everybody that's on the line right now, your line is muted. So what I'm going to do is go ahead and unmute everybody's line. If you don't wish to be unmuted, feel free to just mute yourself right back. And you can also feel free to use your chat box that you'll find in the lower right-hand corner of your screen. Or if you don't see your chat box, just scroll your mouse to the very top and middle part of your screen, and you'll get a drop-down menu that you can see your chat box, and we'll make sure that Dr. Abramson gets those questions. So with that, I'm going to go ahead and unmute everybody's lines. If you have any questions or comments or discussion items for Dr. Abramson, now's a great time.
Hello, Mark.
Yes.
Hi, how you doing?
Good, how are you?
Good. I was curious, you showed that protocol with titration in the lab with that item. What do you think of the matrix to do the same thing?
I think it's wonderful, and I actually was talking to John Nierman, who's titration with the nasal dilation. So we're actually looking for, he's redesigning the matrix trays, and we're looking at having one of the trays have the nasal dilators on, so you can actually see the effect of having with nasal dilation. But it's an excellent option to start off with that, yeah.
Okay, and also you referenced that article, which I've seen referenced before, about the tongue exercises. Can you be a little more elaborate about those exercises?
Well, you can actually go online, and let me go back up to that reference here.
Yeah.
Let me see if I can. Where I had it. There we go. So it's KATIA GUIMARAES et al., which is the Sleep Laboratory and Pulmonary Division of the Heart Institute, University of Sao Paulo Medical School.
Beautiful. And one last question. You were talking about the device you use with the speech pathologists, with that tongue activator. How do you approach speech pathologists and incorporate that into your practice or into their practice?
Well, that's a very good question. We have a speech pathologist here that I was seeing, and I was talking to her about this, and she has a granddaughter who she had tried to correct her speech pathology, which was what they call lateralization of the tongue, and they lose air, and it's one of the most difficult things to treat in speech pathology. And so we brought her daughter in, and she was the first child that we did it with. And within a few weeks, she was speaking correctly within a relatively short time. So what we do with this is, the problem is that we can't contact the speech pathologists that are part of the schools because they don't want to diagnose. Because I don't know where you are, but in California, if they diagnose a developmental problem like that, the school has to pay for the therapy. And we don't have funds to do that. So the speech pathologists are literally told, don't mention if you have, you see a kid's orthodontic problems or retrognathic mandible or anything like that, that they're not supposed to say anything about that. So it's a little difficult there. But what I can get the videos to you. One of the mothers didn't want it on the internet, with her kid on the internet, but she said we could do it, with doctors showing it to people directly. But you can take the videos and take them to a speech pathologist and basically volunteer to do a few cases and see what it does. And my protocol is they just wear it at night when they're sleeping, which makes it very easy. They don't have to worry about losing it. It doesn't hurt. It's very, it's not obtrusive for them. The kids adapt to it very easily. And see them once a month and just video them at the beginning and then video monthly. And usually between 2 to 4 months, then you see a real significant difference. And then they can go back to the speech pathologist who can get them to finish the treatment because now they have the capacity to do what the speech pathologist has been trying to teach them.
That's great. I mean, if you could possibly email me stuff on that, I would love it.
Okay. Rose,
Yes, Mark.
I guess if we can get my email to people.
Well, absolutely. We'll email you the participants, and if you email me, Courtney will email everybody as well.
Okay, that'll be good. Thank you.
All right, we'll get it to you.
Great questions. Any other questions or comments or discussion items anybody'd like to talk about?
No, this was a really great webinar.
Great. Yeah, thank you so much, Dr. Abramson. That was a great presentation. Sounds like everybody's got all their questions answered. And again, thanks so much for taking the time out of your day to teach us all this stuff.
Well, it's always a pleasure working with you guys. It's terrific, and you've done so much for all of us. And I certainly appreciate your effort course, I know how hard it is and how hard you guys work. And thank you for the opportunity to speak.
Well, thank you, Dr. Abramson. We so appreciate it. It was awesome. And Dr. Abramson does have courses. We will be working with Mark next year with some of our own courses as well. And we will, any questions you have, just email us, or any literature you want, we'll make sure we get it to you.
Great. Thank you so much, everybody, for joining tonight, and we'll see you next week.